Hi everyone. We have excellent guest today of our Editor's Choice series by Dr. Simona Sacco at Cephalalgia and International Headache Society. Congratulations, Dr. Mehta. We have Dr. Mehta from London who wrote amazing articles with his colleagues. And that being presented to our audience today. Please, Dr. Mehta, tell us a little bit more about yourself and your colleagues first.
Thank you very much, Nina. So, my name is Dwij Mehta. I'm a neurology trainee, and until recently, I was a clinical research fellow based at the National Hospital of Neurology and Neurosurgery and University College London. And I did my PhD under the supervision of Professor Manjit Matharu. And the theme of the PhD was all things orthostatic headaches. So, looking at the main differentials, spontaneous intracranial hypotension, postural tachycardia syndrome, migraine, as well as craniocervical instability.
Wonderful. Thank you so much for this amazing work. And this article is about orthostatic hypertension. And please, could you tell us a little bit what was the background, what brought you to this interesting article and research?
So I think first thing I would say it was very much a joint effort. So there were lots of specialists involved in this work, and that included neurologists with an interest in CSF leaks, neurosurgeons, specialist nurses, but also patient groups who very kindly helped with this study and got us the outcomes that we achieved. In terms of motivation for this, it was really down to our own experiences when managing patients with suspected cases of spontaneous intracranial hypotension, or SIH for short. One of the things we commonly encounter is if you have a patient with a very typical clinical syndrome with postural headache, you do an MRI, shows features of CSF hypovolemia, plus or minus, it might show some spinal epidural collection, then the framework for how you manage the patient is relatively straightforward. It's more difficult when you have a patient who has features or clinical history that's suggestive of CSF leak. You do an MRI, but you find no evidence of it. And so you're in a tricky situation at that point where, on one hand, you know that certain patients with SIH, about 20% can have a normal MRI brain, and about 50% or more can have a normal spinal imaging. So people with SIH can have normal imaging. But on the other hand, there are differentials to SIH, such as the ones I mentioned before, which is postural tachycardia syndrome. It could be migraine, could be craniocervical pathology, and they all seem to affect a similar age group. And so, do we, in this situation, pursue interventions or management that are quite invasive with the knowledge that earlier management leads to better outcomes in SIH? Or, on the other hand, take a step back and think, well, these are not benign procedures. They can cause harm. And it might be that we're dealing with a non-CSF leak case here. And there is no real way to sort of guide you into either way. So we thought about what are the possible solutions to this. And really, the answer was if the imaging is not going to be helpful in this situation, then the answer surely has to be with clinical phenotyping. And so we reviewed the literature and thought, is there any evidence for specific clinical sort of phenotype that would help us tease apart what the underlying cause is based on the symptoms alone? And there was a distinct lack in our knowledge when it comes to academic or in terms of literature. And so that was really the reason why we went around and we went about doing this study where we characterized the typical characteristics of orthostatic headache in SIH patients.
That's so true. We all seen clinical cases which we have to do diagnostics between those conditions you mentioned. And how did you approach it? What was the
Mm.
method and methods for your research?
Absolutely. And so you're quite right. So what we did was first thing we needed to do was design a questionnaire, a standardized questionnaire that every clinician would use for each of their patients at our unit when they first saw a patient with suspected case of CSF leak. And this would encompass demographics, their past medical history, including their comorbid headache disorders, whether that any connective tissue disorders that may put them at risk of developing a CSF leak, or indeed one of the other differentials that we mentioned. We also looked at what the headache type was at beginning when the symptoms first started, and also the time of the clinical review. And in those that did have an orthostatic headache, i.e., a headache that's brought on or exacerbated by being upright and improves or resolves with lying down, we wanted to find out the characteristics. And specifically, we wanted to know what the baseline severity was when they first woke up, when they were lying down, the time to onset after becoming upright, or time to exacerbation if they already had a headache when lying down, time to peak severity, and then offset to baseline severity when they lie down again. And once we collected all this data alongside the associated symptoms that can often be just as disabling for CSF leak patients, we presented this data to a specialist or specialist interest group, or SIG for short. And this was composed of 5 neurologists with an interest in CSF leak. We had 3 neurosurgeons, again with an interest in CSF leak. We had a patient representative and also a specialist nurse. They would analyze the data and they decided on the centile value for these different characteristics that best represented the typical orthostatic characteristics in SIH, and balancing delicately this importance of having sort of being enough inclusive enough that you have the typical characteristics of almost SIH patient, but not being too inclusive, such that we are clouding the overall typical characteristics with outliers. And so that's what we did.
What did you find out? This is so exciting.
Right, so we had 137 patients. About two-thirds were females, and the average age was 48. We found that orthostatic headaches were present by the time they were seen in clinic in about 75%, and at presentation initial onset around 82%. And in terms of the typical orthostatic headache characteristics that we agreed on were a headache that had an onset or that had a baseline severity of 3 or less on a verbal response scale out of 10, had an onset within 4.5 hours, had a time to peak severity within 7.5 hours, and once they lie down, the offset should be within 1.5 hours. And what we also found, and was agreed by the special interest group or specialist interest group, was that the offset, i.e., the offset to baseline severity on lying down, was probably the most important characteristics when defining orthostatic headaches, which is very different to how we typically think of orthostatic headache. We think of orthostatic headaches are those, how quickly does the headache come on when they become upright? But actually, we look at our results, we found that the inter-patient variability was much less for the offset, as demonstrated by interquartile ranges, which are much narrower for the offset compared to the onset. And so it does pose the question whether we should be thinking of orthostatic headaches more on the basis of offset rather than just the onset.
That's very important that you also mention in some time frames there. And I did
Mm,
see that in the article and also in the graphical abstract coming with that article, that our viewers can clearly see work you've done. And
mm,
what is your conclusion and what's next? I know you mentioned a little bit that
mm.
your PhD work going get published. What's
Mm.
next for you and for the work in this direction?
Yes, so I think it's the main conclusion is for the first time, we have provided an evidence base or some evidence on what the typical characteristics of orthostatic headache is, which is not something that's been done before. And its real utility is not in so much at this stage at excluding SIH in patients who don't fit this typical definition, because there are atypical presentations. We know that. Some people can have no headache at all. So its more utility is actually going back to what I said earlier. If you encounter or if you face a patient who has a postural headache, you do an MRI, you find nothing, and you're left in this tricky situation of, do I proceed with invasive management options, or do I just wait and see if something presents so and keep repeating the MRIs again? Um, it will really help the clinician make a decision in those tricky situations. It's good to have an evidence base for what the typical characteristics are in SIH. But really, going forward, what the study also helps with is really lays down the foundations for future work to be done in similar conditions or the other differentials of orthostatic headaches, so your migraines, your POTS, your craniocervical instability, and see if there are any specific signatures that you can pick up, which are very unique to the condition. Because if you do identify features that can help us tease apart the diagnosis based on symptoms alone, that would really change the way we diagnose SIH, going away from procedures in the past. We used to do lumbar punctures, which were invasive. Now we're doing MRIs, myelograms, to maybe clinical phenotyping. And that would be very good for our patients. So that would be the aim of doing similar studies in other conditions. And lastly, I think its utility is really also in standardizing the way we talk about orthostatic headache in our literature. Because at the moment, there is often very minimal description of what orthostatic headache is when it's described in a paper. And it means that the data is very heterogeneous and it's not really comparable, which only hampers our efforts at furthering the care for our patients with SIH. So hopefully, again, having a typical orthostatic headache definition will help with that.
Thank you very much. We are all hopeful and wishing a lot of success to your
Thank
work
you.
in this direction. Congratulations on Editor's Choice article with International Headache Society Journal of Cephalalgia. And we hope to see you again at the Cephalalgia and Cephalalgia reports with more fantastic work. Thank you so much.
Thank you. Thank you very much, Nina. I really appreciate it.